My name doesn't matter, but my badge number does, because that badge number is on file at a hospital that will tell you, if you call and ask, that no nurse by that number has worked there in 4 years. I worked the night shift in the general medicine ward of a 300-bed hospital for 11 years before I quit. I am telling you this not because I want sympathy, and not because I think you'll believe me. I'm telling you because I need it to exist somewhere outside my own head, written down, said out loud, given to strangers who can decide for themselves whether I'm insane. I have decided I don't care anymore which one it is. I just need it to not be only mine. I started nursing because my mother died in a hospital bed when I was 19. And I remember thinking, watching the machines, that somebody should be paying closer attention than they were. Somebody should be in the room. That's a naive thought. I know that now, because hospitals are not built for somebody to always be in the room. They are built for the appearance of attention. Lights that blink, charts that get initialed, vitals taken every 4 hours unless the patient is critical, in which case it's every hour. In which case you are now responsible for 6 other patients who are also supposedly being checked every 4 hours. And you are one person. And the night is 12 hours long. And there is no version of this job where everyone gets watched the way my mother should have been watched. I tell you all of that, so you understand the job before I tell you about the beds. On the night shift, every nurse does what's called a bed check at the top of the hour. You walk the hall, you look in each room, you confirm the patient is there, breathing, not in distress, and you move on. It takes maybe 45 seconds per room if nothing's wrong. In a 16-bed wing, that's 12 minutes out of every 60, which sounds like nothing until you remember you're also charting, also answering call lights, also pushing meds, also being the only adult in the building who knows that Mr. Alvarez in 14 gets anxious around 2 a.m. and needs someone to just sit with him for 90 seconds so his heart rate doesn't spike. People who've never worked nights imagine a hospital as a place that runs the same 24 hours a day, just with fewer people around to see it. That isn't true. A hospital at 2 p.m. and a hospital at 2 a.m. are not the same building. At 2 p.m. there are families in the halls, doctors making rounds in packs of 3 or 4, housekeeping carts, the smell of lunch trays, a kind of human static that fills every corner whether you want it to or not. At 2 a.m. the lighting changes. Half the overheads switch to a dimmer setting automatically, on a timer, so the whole building drops into this low amber hush. And the sound changes, because the HVAC and the elevators and the ice machine down the hall are suddenly the loudest things in the building, louder than any person. You walk the same 16 rooms you walked at 2 p.m., and they are the same rooms, and they are not the same place. I think that matters to what I'm about to tell you. I think the thing I encountered only exists in that second version of the building, the night version, the one that's almost the same as the day one but isn't. In my first few years, every bed check was unremarkable. A patient is there or a patient isn't, and if they aren't, it's because they're in the bathroom, or down in imaging, or a family member checked them out for a walk against everyone's better judgment. You learn the rhythm of a ward, the way you learn the rhythm of a house you've lived in a long time. You stop consciously noticing things that are normal. What I want you to understand is that for the first 6 years of my career, I genuinely do not remember a single empty bed that didn't have an explanation, not one. I want that on the record because what happened later is going to sound like something I built up slowly in my mind, a thing I trained myself to see. And I need you to know that it didn't start slow. It started in a single night, and before that night, there was nothing. And after that night, there was something, every night, for 5 years, until I left. The night it started, I was working a wing I didn't normally work, We were short-staffed. We were always short-staffed. And I'd been pulled from medicine to cover oncology because 2 nurses had called out with the flu. I didn't know the patients. I didn't know the room numbers by heart the way I did on my own floor. I was working off the chart and the chart alone, which matters, because it means I had no personal familiarity to fall back on. I was reading numbers off a clipboard and matching them to doors. Room 412 was charted as occupied. A woman, 68, post-op, stable. I opened the door at 1 a.m. for my check, and the bed was empty. Not unmade. Empty and made, sheets tucked, pillow squared. The kind of empty that looks like nobody has been in that bed in days. Not the kind of empty that looks like someone just stepped out. I checked the chart again. Occupied. I checked the wristband log at the nurse's station. Patient confirmed present. Last vitals taken at 9 p.m. Normal range. I asked the other nurse on the floor, a woman named Denise, who'd been there 18 years, if the patient in 412 had been moved. Denise looked at the chart, looked at me, and said, "No, she's there. Did you actually open the door?" I had. I told her I had. Denise didn't even get up from the desk. She said, "Check again. Sometimes you don't see them right away." That sentence didn't register as strange to me in the moment, because I was new to the floor and assumed she meant something practical. Patients curled up small, hidden by blankets, easy to miss in dim light. I went back. I turned on the overhead light this time, instead of just the night light by the door. The bed was empty, made, untouched. I want to skip ahead slightly, because the next part is the part where I started lying to myself. And I think it's important to say that out loud rather than pretend I handled this well from the start. What I did was this. I told myself the patient must have died and been moved to the morgue without the chart being updated yet, which happens, paperwork lags, and a death at 9:30 p.m. could easily not be reflected by 1 a.m. if the floor was busy. I told myself this so firmly that I actually wrote it in my own notes. PT status unclear, possible discharge or transfer not yet charted, and moved on with my shift. I did not call anyone. I did not flag it as urgent. I made it administrative, because administrative things don't keep you awake. In the morning, the day shift told me the patient in 412 had passed away at 9:40 p.m., 10 minutes after her last charted vitals. No one had been in the room with her. The official note said she'd been found unresponsive at the 10 p.m. check, which would have been the very check I performed at 1 a.m., except the time didn't match anything I'd actually done. And when I tried to ask about the discrepancy, the charge nurse told me the time on these things is always a little soft, and not to worry about it. I want to be honest about something. For a long time after that, I thought what I'd witnessed was simply death itself. That I had walked into a room 10 minutes after someone died, and some part of me had registered the room as wrong in a way I couldn't name. And my brain, untrained in that particular wrongness, had filed it as empty rather than as recently vacated. I built a whole explanation. I was proud of that explanation. It let me keep working. It happened again 4 months later, then twice the month after that. By my 3rd year on nights, I had stopped being surprised by it and started, God help me, anticipating it. I would walk into a bed check already braced for the possibility that the room would read as empty, even though the chart said occupied. And more often than not always, but more often than chance should allow, I'd be right. And every single time, without exception, in the years I tracked it, the patient charted as occupying that empty bed died within the hour. Not the day, not the shift, the hour. I started keeping a private log, not in any official chart, in a notebook I kept in my locker. because some instinct in me knew this was not something to put my name to in hospital records. Room number, time I found it empty, time of death once confirmed, 5 years of entries. I have that notebook still. I am not going to tell you how many pages it fills. Here is the part I avoided understanding for as long as I possibly could, because once you understand it, you cannot work the job the same way again. The empty bed was not a malfunction of the chart, and it was not a trick of poor lighting, and it was not me misperceiving a death that had already happened. The bed was empty because, for that hour, there was no one to see into it. Not because the patient wasn't there, because something about dying, the specific kind of dying that happens when no family is present, when no nurse is in the room, when a person crosses over entirely alone, makes a person briefly unwitnessable, present in every record, present on the monitor, present in the bed by any objective measure, but not there for the one person walking the hall who is supposed to be the last human attention they'll ever receive. The building, or the job, or whatever you want to call the thing that runs underneath a hospital at 3 a.m., was selecting for the deaths nobody saw. And I was the instrument it used to make sure nobody did. Denise, when I finally worked up the courage to ask her directly 6 years in, after I'd seen it enough times that I could no longer pretend it was coincidence, told me something I have never been able to stop turning over. She said, "Everyone who's done this job long enough gets shown the same thing eventually. The only people who don't get shown it are the ones who never really looked." And then she said, "The trick, sweetheart, is to stop counting. The minute you start counting, it starts counting you back." I didn't understand that sentence for almost 3 more years. I understand it now better than I've ever understood anything in my life. In my 8th year, a younger nurse named Priya transferred onto our floor from labour and delivery. She was sharp, fast, the kind of nurse who triple-checks everything because she doesn't yet trust her own instincts to be enough, which is exactly the kind of nurse who notices things the rest of us had trained ourselves not to. 3 weeks into nights, she came to me during a lull and asked, very carefully, like she was testing whether I'd laugh at her, if I'd ever walked into a room that read occupied on the chart and found it empty. I told her the truth. I told her everything I've told you, except the part about my own private theory, because by then I had a theory, and I wasn't ready to say it out loud to someone who hadn't lived it yet. Priya didn't laugh. She got very still, and she said it had happened to her twice already, both times in her 3rd week, both times a patient whose bed read empty died within the hour, and both times the official time of death came back 10 minutes after the last charted vitals. The same 10 minutes, every time, like a toll being collected on a fixed schedule. She asked me if that 10-minute gap was always the same. I told her yes. I had never told anyone that detail before, because writing it down felt like giving it more reality than I could afford it to have, but she had clearly already found it on her own, in her own log, in her own handwriting, in her own locker. Priya transferred out 6 weeks later, back to labour and delivery, no explanation given beyond wanting more predictable hours, which on a maternity floor is frankly a joke, because nothing is less predictable than labour. I ran into her 18 months after that in the cafeteria, and I asked her, carefully, the way she'd once asked me, whether she still thought about it. She looked at me the way you look at someone who's brought up an ex you'd successfully stopped thinking about, and she said, "I stopped counting. You should stop too." Then she picked up her tray and found a table on the other side of the room, and we have not had a real conversation since, though we still nod at each other in the hallway sometimes. 2 women who know the same thing and have agreed, without ever discussing it, not to know it together. I think about Priya almost as much as I think about Denise. Denise had decades of practice not looking directly at it. Priya had 3 weeks, and even she understood, faster than I did, that the safest thing to do was stop counting and walk away from the floor entirely. I was the only one of the 3 of us who kept going. I don't know if that makes me the bravest or the stupidest. Some nights, I think it's the same thing. What changed, what finally pushed me past, simply documenting this in a locker notebook and into the territory of genuine, bone-deep fear, happened on a Tuesday in my 11th year, on a night that started exactly like every other night. I did my 9 p.m. round, 16 beds, 16 patients, all accounted for, all normal. At 10 p.m., I did the round again. 15 patients accounted for. Room 408 read empty on a visual check, occupied on the chart. An elderly man named Walter, admitted for pneumonia, stable, expected to be discharged within the week. I logged it the way I'd trained myself to log it by then. Time, room, no panic, just observation. Because panic never changed the outcome, and I'd learned that the only thing I could control was whether I treated this as ordinary. At 11, Walter's bed read occupied again. He was there. Sitting up, in fact, awake, asking for water, completely normal, completely fine. No sign of distress. Vitals excellent. I remember feeling something close to relief. Maybe I'd misread the room an hour earlier. Maybe this was finally the night the pattern broke. I got him his water. I told him to get some rest. He thanked me by name. That's the detail that still takes my breath away when I think about it, even now. He thanked me by name. I had never told him my name. My badge was turned backward that whole shift. It had flipped on its clip, and I hadn't noticed, hadn't fixed it, so there was no possible way for him to have read it. I asked him, half joking, how he knew what to call me. He looked at me with an expression I can only describe as gentle confusion, the way you'd look at someone who asked you how you knew the sky was blue, and he said, "You told me last night. Don't you remember?" I had not worked the previous night. I'd had it off. Denise had covered the floor alone. I went back to the nurse's station and I pulled the prior night's chart, and there, in Denise's handwriting, in the 2 a.m. entry for room 408, was a note that made the hair stand up on my arms before I'd even consciously finished reading it. It said, "Patient alert, conversational, asked nurse by name, confirmed via badge. Patient stated nurse had checked on him earlier in the evening, though nurse was not scheduled." Denise had written my name in that chart. The night I wasn't there. I did not sleep after that shift. I drove home, sat in my car in the driveway for 40 minutes, and then I drove back to the hospital and asked to see the security footage from room 408's hallway camera for the previous night, the night I supposedly hadn't been there. I was told, politely but firmly, that hallway footage older than 72 hours is automatically overwritten, and that night was outside the window by 6 hours. 6 hours. Not 6 days. 6 hours past the point where I could have proven, one way or another, whether I had been standing in that hallway while I was, by every official record, asleep in my own bed 40 minutes away. I went back to room 408 at midnight on my next shift, the same room, 3 nights later. Walter had been discharged by then, gone home, pneumonia cleared, a genuine recovery, no trick, no twist. I want to be clear that nothing happened to Walter. He's fine. He's probably still fine right now, wherever he is, completely unaware that his hospital room is the reason I quit nursing. The bed was empty in the ordinary way, freshly stripped, waiting for the next patient. Nothing wrong with it. I stood in that doorway anyway for almost 10 minutes, just looking at it, because I needed to know whether looking at an objectively, mundanely empty bed still made my chest feel the way it had felt every other time, and it didn't. It felt like nothing, which meant I could still, after everything, tell the difference between an empty bed and an empty bed. Some small, useful part of my mind was still working correctly. That was almost worse than if I'd lost the ability entirely, because it meant I wasn't confused. I was correct. About all of it. I worked 4 more months after that. I kept my notebook. I stopped trying to explain anything to anyone, including myself. And then, on what turned out to be my second to last shift, I did my 3 a.m. round, walked past my own assigned break room. Not a patient room, a staff room, a door I had walked past 1,000 times, and the little reinforced glass window in the door showed it empty in the way I had come to recognize. Not unoccupied, empty in the specific wrong way, made up, waiting. Charted, in some sense I had no proof of and every certainty about, as occupied. I did not open that door. I have never opened that door. I gave my notice 11 days later, and the official reason I gave my manager was burnout, which is true, just not in the way she understood it. On my actual last shift, I did something I'd never let myself do before. I asked Denise, point blank, whether she had ever, in 18 years on that floor before I arrived, considered leaving the way I was leaving. She was quiet for long enough that I thought she wasn't going to answer at all. Then she told me that this was her 31st year, not her 18th, that the 18 years was what she'd told me when I started, because 18 sounded long enough to be credible, without sounding long enough to invite the question of why anyone would stay somewhere like this for 31. She said the math on staying versus leaving stopped feeling like a real choice somewhere around year 10, because by then you've already been counted. And once you've been counted, leaving the floor doesn't undo it. It just changes which building you're standing in when it happens. I asked her what it was. She said, "You know what it is. You've known for years. Saying it out loud doesn't make it more true. It just makes it harder to pretend you don't carry it home with you." Then she hugged me, which she had never done before in 11 years of working beside her, and she said, "Go be tired somewhere else for a while." And that was the last real conversation we ever had. I think about Denise's sentence more than I think about almost anything else from those 11 years. The minute you start counting, it starts counting you back. I think what she meant, what I now believe with the kind of certainty that doesn't require anyone else's agreement, is that the hospital, or whatever moves through a hospital at the hours when almost no one is awake to watch it work, doesn't care whether you see it. It only starts to notice you once you start trying to keep score. Once you become someone who counts the empty beds instead of someone who simply walks past them, you've told it something about yourself. You've told it you're the kind of person who pays attention. And it has a use, apparently, for people like that. It had a use for me for 11 years. I don't know if it still has a use for the version of me that quit. I don't know if quitting is something you're actually allowed to do, or just something you're allowed to believe you've done. I work in an outpatient clinic now, 9 to 5. Every bed I see during the day has a person in it who I watched walk in under their own power an hour earlier. I have not seen an empty bed in the 2 years since I left. I check, sometimes, on slow afternoons, room by room, for no clinical reason at all. I tell myself I'm just being thorough. But I'll tell you the thing I haven't told anyone. Not even the version of this story I rehearsed in my head 100 times before finally writing it down. 6 months ago, my clinic ran an evening hours pilot, 3 Thursdays a month, 6 to 9 p.m., to accommodate patients who couldn't make daytime appointments. It was barely night. The sun wasn't even fully down for the first hour. But on the second Thursday, doing a routine check of an exam room between patients, a room with no chart, no bed, Nothing but a table and a blood pressure cuff and a poster about diabetes management. I felt it. That specific, wrong stillness. The room was objectively, mundanely empty, exactly as it should have been. Table clear, lights on, door unlocked. And it still felt occupied in the way a chart says occupied when a room is empty, if that makes any sense at all, which I know it doesn't, except to the very small number of people who will read this and feel something cold move through them because they already know exactly what I mean. I did not log it. I do not have a locker anymore. I stood in that doorway for almost a minute, and then I closed the door, and I have not gone back into that particular exam room since, even though it is, by every reasonable measure, the most ordinary room in the building. I never found out who wrote my name in that one night's chart, in a hand that wasn't Denise's after all. I had it wrong, that detail, when I first decided to tell this story, and I corrected it for you because I promised myself I would not let this account be more frightening than the truth actually is. It was Denise's hand. I confirmed that twice. I want you to have the truth, plain, the way I lived it, not the version that's easiest to be afraid of. The plain version is frightening enough. A hospital at 3 a.m. is a building full of people who are, for 1 hour out of every life, completely alone, whether or not someone is standing in the doorway looking in. I spent 11 years being the person standing in the doorway. Some nights, I was apparently standing there even when I wasn't there at all. I don't have a tidy ending for you. I don't have proof, and I'm not going to pretend the notebook means anything to anyone but me. What I have is 11 years of bed checks, a sentence from a woman who's been doing this longer than I have, a name I never gave a man who somehow knew it, an exam room with no chart and no history that still managed to feel exactly the way room 412 felt the first time I understood what I was looking at, and a feeling, when I pass a hospital now, even just driving by at night, of every window holding a room I used to walk into, and a bed I used to check, and a held breath I'm still, somehow, waiting to let out. If you've worked nights in a hospital, or anywhere people are left alone in the hours when almost no one is watching, I'd believe you if you told me you've seen something like this too. I think more people have than will ever say so out loud. I think the ones who have learned, the way Priya did, the way Denise did, the way I eventually did, that the only thing worse than seeing it once is being the kind of person who keeps count.